Hello dear students. Today we are going to learn about the torch infections. Torch infections are common infections around the perinatal period and are the common cause of the birth defects in developing countries. T for Toxoplasmosis, R for Rubella, C for Cytomegalovirus and H for Herpes virus. O is for other viruses like HIV, HBV, HCV, and syphilis infection, and Parvovirus B19 infections. First, we will discuss about the congenital toxoplasmosis. Congenital toxoplasmosis is caused by intracellular parasite Toxoplasma gondii and transmitted transplacentally during the primary maternal infection. And the risk of transmission increases with increase in the gestational age. However, the severity decreases as the gestational age increases, and it is most severe if acquired by the fetus during the first trimester, and it is most severe if acquired during the first trimester and least severe if acquired in the third trimester. Classical triad includes the chorioretinitis, that is inflammation of chorion and retina. Second is hydrocephalus. Look at this head, it is enlarged in size due to the accumulation of fluid in the ventricular spaces and arachnoid spaces. And diffuse intracranial calcifications. So it consists of three things. First is chorioretinitis, second is hydrocephalus, and third is intracranial calcifications. Other signs may include seizures, hepatosplenomegaly, jaundice, growth restriction, hearing loss. Diagnosis can be made by the maternal IgM IgG serology, fetal PCR from the amniotic fluid, postnatal IgM or persistence of IgG. Treatment for the congenital toxoplasmosis should be started immediately, and it consists of pyrimethamine plus sulfadiazine combination along with folinic acid, or it is also known as leucovorin, and this treatment should be given for at least 1 year. Prevention can be done by avoiding to eat raw food or undercooked food or meat, avoiding the contact with the cat feces during the pregnancy, and treatment of the maternal infection during pregnancy. Now come to the second congenital infection, that is congenital rubella syndrome. It occurs due to the maternal rubella infection, especially in the first trimester. And classical triad consists of sensory neural hearing loss, ocular defects including the cataract, microphthalmia, pigmentary retinopathy, that is salt and pepper retina, and third is congenital heart defects including the patent ductus arteriosus or pulmonary artery stenosis. Sensory neural hearing loss mainly is for high frequencies due to the damage of eighth cranial nerve. and it is usually bilateral, and it is the most common feature. Other thing is the presence of a rash in baby due to the thrombocytopenia, which is known as blueberry muffin rashes. Look like the blueberry muffin, and this picture shows the rash, history of rash in the mother during the pregnancy. Other features include microcephaly, hepatosplenomegaly, and growth retardation. Diagnosis can be made by infant IgM levels, persistent IgG for more than 6 months, or PCR for rubella RNA. Prevention can be done by the MMR vaccination before pregnancy, which is contraindicated during pregnancy because it is a live vaccine, so it cannot be given during pregnancy. Now come to the congenital CMV infection. It is the most common congenital infection, especially after the primary maternal CMV infection in early pregnancy. And major risk factor is the exposure of mother to young children, and mothers who are working in the daycare center are at highest risk of getting infection from the saliva or urine of the children. And prevention is very easy by avoiding any contact with the saliva or urine of the children and by maintaining the hand hygiene. Most of the newborns are asymptomatic at birth but can develop sequelae later in their life. Most common clinical presentation is of sensory neural hearing loss and periventricular calcification and microcephaly. In this picture, this newborn has microcephaly. This picture showing the intracranial calcifications, and this picture is showing the blueberry muffin rashes due to the thrombocytopenia, and this picture showing the inclusion body in the placental tissue. Diagnosis can be made by the detecting the CMV DNA by PCR. Treatment includes the IV ganciclovir or oral ganciclovir. Now come to the neonatal herpes infection. Neonatal herpes is caused by HSV2 mainly, and in some cases by HSV1. It is transmitted by the peripartum route during the peripartum period, and not through the transplacental route. And the clinical features include the three forms of the disease. First is the localized skin, eye, and mouth involvement, that is the SAM. Second is the CNS disease, and third is sepsis like presentation, which is known as disseminated disease. Disseminated disease has the highest mortality rate. CNS involvement causes neurological deficits and seizures. Skin, eye, mouth disease usually get resolved without any sequelae but requires treatment with acyclovir for 14 to 21 days. Prevention can be done by avoiding the contact of the fetus when it passes through the birth canal to come in contact with the genital lesions of mother, which are caused by the herpes virus infection, and this can be done through delivering the newborn with the cesarean section. Now come to the congenital syphilis. It is caused by the Treponema pallidum, transmitted transplacentally from mother to the fetus. And presentation can be early or late. Early clinical features occur before the age of 2 years, and late clinical features occur after the age of 2 years. Early clinical features include the hepatosplenomegaly, jaundice, anemia, thrombocytopenia, failure to thrive, snuffles, that is rhinitis, and causes the profuse mucoid bloody nasal discharge, and it is highly infectious during this period. Other features include maculopapular or bullous rashes on palms and soles, and this is the bullous rash or pemphigus due to the syphilis. Other clinical features include the osteochondritis, periostitis, and metaphysiatis, which causes the painful limbs, due to which the newborn is not able to move his or her hands, and this looks like a paralysis, but it is not a paralysis. So it is known as pseudoparalysis of parrot. Pseudoparalysis of parrot. Parrot was the name of scientist who discovered this feature. Another feature is the Wimberger sign. Wimberger sign. It is the bilateral destruction of proximal tibia. And other clinical features include the seizures, hydrocephalus, hearing loss, and pneumonitis. Late clinical features include the Hutchinson triad. Hutchinson triad include the interstitial keratitis, Hutchinson teeth, and sensory neural hearing loss. Hutchinson teeth is the notched upper central incisor, like in this picture. These are the Hutchinson's teeth, and I is for interstitial keratitis. Interstitial keratitis. SNHL occurs due to the involvement of 8th cranial nerve. Other clinical features are mulberry molars, high arch palate, saddle nose deformity, frontal bossing, and perioral fissures and scars. In this picture, this child has saddle nose, perioral fissures. Other features are sebaceans, that is the anterior bowing of tibia, Clutton joints, that is the bilateral painless swelling of knees or elbows due to the synovitis. And other clinical features include the intellectual disability, optic atrophy, hydrocephalus, and seizures. Diagnosis can be made by the RPR, VDRL in infants, and comparison of it with the maternal titers. And it can be confirmed with the FTABS or TPPA test. Treatment include single dose of penicillin, benzathine penicillin G intramuscularly. Prevention can be done by the routine antenatal screening and maternal treatment with penicillin during pregnancy. Now come to the another infection, that is the congenital varicella syndrome. It is caused by the primary maternal varicella zoster virus infection, and if especially if it occurs between the 8 to 20 weeks of gestation, then it has highest chance of transmission from mother to fetus transplacentally. And classical features of um, congenital varicella syndrome include the limb hypoplasia, cutaneous scars, as we can see in this picture, scars in especially in the dermatomal pattern, involves a dermatome of the skin, and ocular defects include the chorioretinitis or microphthalmia. Other findings may include microcephaly, cortical atrophy, seizures, low birth weight, and GI dysfunction. Neonatal varicella can be severe if occurs within the 5 days before or 2 days after delivery. So this period, that is the if delivery occurs day 0, then 5 day before and 2 day after the delivery. This period is very crucial, and diagnosis can be made by the PCR for the VZV DNA. Prevention can be done with the VZV vaccination before pregnancy, or give immunoglobulins for exposed pregnant women or newborns at risk. Now come to another infection, that is the congenital HIV infection. It is caused by the vertical transmission of HIV during the pregnancy. First, during the pregnancy, that is in utero transmission. Second is the during the delivery or labor, that is intrapartum transmission. And third is during the breast feeding, that is postnatally. If mother has higher viral load, then the risk of transmission increases. But the highest risk of transmission is during the intrapartum period or during the labor or delivery period. Without intervention, transmission risk is 15 to 45%, highest in the intrapartum and least in the feeding period. Risk factors which increases the risk of transmission from mother to fetus include the higher load, higher viral load. Second is if mother is not taking any ART, that is antiretroviral therapy, and if mother has advanced stage of HIV or AIDS, if she is having the chorioamnionitis, that is the inflamed chorion and amnion, which causes the increase gap between the cells and easily transmission of the virus from mother to the uh, fetus. And other features include the other risk factors are the premature rupture of membranes and breastfeeding without if mother is not taking ART, breastfeeding, if delivery is done with vaginal route, so cesarean section should be preferred. along with ART to prevent the transmission. And if mother has other sexually transmitted infection along with the HIV, then the risk of transmission also increases. Most infants are asymptomatic at birth. They have no symptom. And however, in some cases, failure to thrive may be there, chronic diarrhea may be there, and lymphadenopathy can be seen. Oral thrush can occur in some patients due to the candida infections, which is an opportunistic infections. Other opportunistic infections include the PCP pneumonia, CMV infection during the infancy period. Neurological signs include the developmental delay, encephalopathy, and microcephaly. Diagnosis can be made by the use of HIV PCR at birth. Timing of the testing are the at birth, at 2 weeks, at 1 to 2 months, at 4 to 6 months. Maternal antibody persists for the 18 months in the newborn. Prevention can be done with the universal antenatal screening, use of highly active antiretroviral therapy, infant prophylaxis with zidovudine, and use of formula feeding if feasible. Next infection is congenital HBV infection. It is most commonly transmitted during the peripartum period, like HIV, especially if mother is HB S antigen and HBe antigen positive. It shows high infectivity. HBe positivity means high infectivity due to the high viral load. And risk of neonatal infection is more than 90% in these cases, in such cases. And most infected infants are asymptomatic at birth but have chronic infection which persists for longer time, chronic infection, and which persist and causes the liver damage later, and it can be prevented by use of HPV vaccination and by giving HBIG, that is the hepatitis B immunoglobulins, within the 12 hours of birth, followed by vaccination at their regular time, that is 0, 1 and 6 months. C-section not routinely needed in these cases. However, maternal antiviral therapy should be started with tenofovir, which is sufficient to prevent the transmission to the fetus, because mainly it occurs during the peripartum period. Last thing in the congenital HBV infection, that it cannot be transmitted by the breastfeeding. So there is no need of use of formula feeds in these babies. Now come to the congenital HCV infection. It is transmitted from mother to the fetus during the intrapartum period, like HBV virus infection. It cannot be transmitted transplacentally. It cannot be transmitted by breastfeeding. C-sections are not helpful Similarly, in HBV, C-sections are also not helpful, and uh, use of the anti-HCV drug in pregnancy is a question mark, because there are no uh, enough literature then when we have to start its treatment during the pregnancy. So we have to wait until the delivery of the uh, baby to start the anti-HCV treatment. There is no vaccination for the HCV virus, and so there is no role of any prophylaxis. HCV RNA PCR is can be done after the 2 to 3 months to detect its load in the in the newborn, or anti-HCV antibody can be detected after 18 months in the newborn when the mother's antibody wane off. Usually it does not cause any symptom, that is patient remain asymptomatic, newborn remain asymptomatic, but can develop chronic hepatitis later in approximately 15% of cases. Now come to the congenital parvovirus infection. Parvovirus infection causes the fetal anemia because it causes the PRCA, pure red cell aplasia. So fetal anemia leads to the hydrops, non-immune hydrops, and intrauterine fetal demise can occur. Patient can also have hepatosplenomegaly, cardiomegaly, placentomegaly. Diagnosis can be made by maternal serology, amniotic fluid PCR, or fetal USG for hydrops. There is no specific treatment, so the treatment modality includes the intrauterine transfusion to prevent the hydrops due to the severe anemia. And mainly the infection occurs during the second trimester, and during that phase it transmitted transplacentally to the fetus. So today we have discussed about the torch infections and their effects on the newborn. Thank you.